I really appreciate the opportunity to come and spend about 20 minutes talking about the clinical electrophysiologic approach to atrial fibrillation. And when I put my talk together after getting the topic from Sam, I actually didn't realize that we were going to be hearing about epidemiology and novel anticoagulation agents and warfarin. So you'll see that the slides that you have include all those things. But I've really tailored this to really cover areas that aren't being covered and really complement it. And with that background, I think a good starting point, as always, is with the patient. It gives us context and focus, and it is, after all, the most important thing that we do research for, do education for, and participate in clinical care for. And in this particular instance, just a couple months ago, my boss called me because he had a 68-year-old male in for a routine annual cardiovascular evaluation. He had a history of hypertension and had had a stent in 2001. But he'd been fatigued with exercise intolerance for about 6 weeks. He got short of breath, dyspneic on exertion, but he'd not had any chest pain, no angina. He'd been on a variety of medications, including a beta blocker, a diuretic, aspirin, medication, an ACE inhibitor, lisinopril for high blood pressure, and a statin. And a stress test that had been done just about 2 years ago showed that he actually had very good exercise capacity. His heart muscle function was normal. I know there's some lay people in the audience, and this ejection fraction represents the heart muscle function. And importantly, he was getting very good supply to his heart, blood supply to his heart. His blood pressure was a little low. His heart rate was very rapid and irregular. And he actually had some crackles at the base of his lungs. And also had a S3 gallop, indicating that his heart was working a little bit hard, and some ankle edema. So he had developed some symptoms of heart failure. Now his EKG showed the classic EKG of an irregular, regular rhythm with a rapid ventricular response. No acute changes, but he was in AFib. And I really went through this because it represents sort of state-of-the-art treatment of AFib. We admitted him, we did some routine labs, made sure his thyroid was okay and that he wasn't having a heart attack. We gave him low pressure orally and intravenous heparin, keeping in mind he'd only been on aspirin. We actually did a transesophageal echo, looked through his esophagus to make sure that there was no clot, but noticed that his ejection fraction was now down to about 30 to 40%, and it was globally not moving well. Really an indication probably of the atrial fibrillation causing a relatively acute tachymyopathy where the heart muscle function was weak and he developed symptoms of heart failure. So we initiated a drug, dronedarone, twice daily. We started dabigatran, we cardioverted him, and importantly for our length of stay, always important these days, we discharged him within 24 hours of admission, and very importantly, 2 months later he's done extremely well. It's now 3 months. He's in sinus rhythm. His ejection fraction is now normalized. And with that background, recognizing that much of the epidemiology and novel anticoagulant agents have been covered, I thought I'd really focus on a lot to do with the pathophysiology and mechanisms, but make a couple of important points for perhaps in the non-cardiology people here. Under normal circumstances, the impulses start right up here in the sinus node, travel through this AV node. It's kind of a toll booth that slows things down, and it's represented as such here, and then activates the ventricles. And when the atrium contracts, and then it's followed by ventricular contraction, the heart works very, very effectively as a pump. Now, by contrast, when somebody goes into atrial fibrillation, and just go back up to that, what happens is that normally, early in AFib, there's a site, commonly in the pulmonary veins, and that'll be a recurrent theme, that now comes on and assumes the dominant control of the heart. It suppresses the sinus node, but notice that the ventricular response is actually slowed by that AV node. So much of the therapy that we implement is to slow conduction through that AV node, but the heart does not function as efficiently as a pump, and with time, particularly if the rates are rapid, the heart muscle can weaken relatively acutely, as happened to this gentleman over a few weeks, and it can get normal again, a so-called tachymyopathy. Now, we've purposely represented the AFib coming from a pulmonary vein because early on that's where it comes from. In the spectrum of AFib, if we look at the individual patient, typically somebody who's perhaps hypertensive, perhaps with diabetes, They have a normal heart and normal left atrial size, and they develop this focal driver coming from the pulmonary vein. And in that context, the mechanism is a focal site that just takes over, as we showed in the graphic. We treat those people with, obviously, initially a history physical, make sure their thyroid function's okay, make sure that there's no drivers like caffeine or alcohol or physical or mental stress. And then we'll institute drugs, commonly beta blockers, and these are excellent patients for focal radiofrequency ablation. Now, in that same patient, as the AFib persists over time, they develop left atrial enlargement. The left atrium actually mechanically remodels. It stretches, and the electrical impulses also change in ways that we'll show. And it becomes persistent. It goes from that focal site to now reentrant propagation, and it's more difficult to control. Commonly, we have to go with rate control and, if needed, appropriate anticoagulation based on the CHAD score, which I'm sure you heard a lot about. And then finally, the left atrium commonly will dilate even more if they have coronary disease or myopathies. The left ventricular function goes down, and they develop permanent AFib, and it's extremely difficult to control that in terms of reestablishing sinus rhythm. So we go with rate control and anticoagulation, and we can try this linear ablation, but frankly, the risks are high and the outcomes are not good. So we want to catch these people at this stage. Now, AFib has a lot of symptoms. As this gentleman, it decreases LV function. It can cause this myopathy. There's actually a twofold increase in cardiac mortality and a fivefold increased risk in stroke. And so it's a very significant burden to the healthcare system, and every bit as debilitating as many other debilitating diseases like severe rheumatoid arthritis. And mechanistically, really, there was a seminal observation by my colleagues in France, Michel Hasseguer, in which they found that the pulmonary veins actually were the site of origin and could be ablated. So early on, AFib comes from these pulmonary veins. It progresses from paroxysmal to persistent, becoming more reentrant, and then it actually becomes a large reentrant circuit as it becomes more permanent. So as the disease progresses, it becomes mechanistically quite different. Now, there are actually fibers that invaginate into the pulmonary veins in the left atrium, and these fibers serve the role of actually collapsing the veins. There are no valves in them when the atrium contracts, and they are in fact the site of origin that can be ablated early on in patients with paroxysmal AFib. As the AFib progresses, there then develops reentry. There also can be non-pulmonary vein sites, such as the coronary sinus, the right atrium, and the superior vena cava. And then finally, there can be multi-mechanisms in patients with more advanced disease. So fundamental to preventing AFib is understanding the mechanism, and fundamental to treating it is actually making sure that you understand the mechanism in the individual patient. In that respect, early ablation in these patients works well. Primordial prevention is really something that's de-emphasized, and I'll say more about it, but that refers to prevention of risk factors such as hypertension and diabetes with diet and exercise and lifestyle modifications, which is really probably the most important thing we can do to prevent AFib. So early on, it's atrial premature beats that shorten the electrical activity in these reentrants. It modifies the autonomic tone. It stretches the atrium. And then maintaining it, there are a number of factors that remodel the atrium, both mechanically, the atrium stretches, and electrically. The wavelets develop, the refractory periods shorten, the conduction velocities go out. And these go on in 4 distinct time zones that we don't need to go on into great detail: short term, moderate term, and very long term. And with that, there are very distinct changes in the channels that actually cause the electrical depolarization of the heart. Now, this fibrosis that comes up is a repetitive theme, and it's really important because there's been some indications that inflammation, which is reflected here with a biomarker C-reactive protein, is low in control patients, but in patients with AFib, be it lone AFib or AFib with heart disease, is higher. And as patients go from controls to paroxysmal to persistent, there's a persistent increase in this inflammation. And this is really probably a clue to one of the mechanisms. Now, in that respect, as you think, we've looked at statins to reduce inflammation It looks very good acutely in post-op patients, and it looks like it helps long-term, but there really hasn't been any prospective study that's conclusively shown that statins prevent AFib at all. The same thing with what looked like very good data early on with fish oil. Retrospective analysis and prospective analyses has not held up either. So neither statins nor fish oil nor anything that blocks the renin-angiotensin system, including medications that are designed specifically to block the effect of aldosterone. When there is left atrial stretch, there's atrial and ventricular fibrosis through that stretch, and it was hoped that ACE inhibitors or perhaps spironolactone might prevent AFib, but the trials that have been done with the limitations haven't shown that either spironolactone or ACE inhibitors, although if you put many trials together, it looked like there's an effect that it may be reduced. It hasn't really been clinically validated to the point that it's been incorporated into any of the guidelines for using statins, fish oil, spironolactone, or ACE inhibitors for prevention of AFib. And I say that because obviously as much as we can do to prevent this process, the better off we're going to be. We always look for acute causes that can be reversed, triggers in individual patients, and that's the basic part of what we do before we go on to more advanced therapy. With the therapy, we try to prevent stroke, slow the ventricular response, selectively restore and maintain sinus rhythm, improve symptoms, improve the quality of life, which is measured in most trials, and reduce costs while prolonging survival. And that's a very tall order, but that's actually the goal. And in the remaining 8 or 9 minutes, I'm going to go very quickly through the rate control options, the maintenance of sinus rhythm, both pharmacologically and non-pharmacologically. And I'm not going to say too much about stroke prevention because I know that this has been emphasized before. But symptoms really drive our decision making. And if an individual such as the one that I showed you at the beginning had come in with minimally symptomatic or asymptomatic AFib, we would have seriously considered a strategy of just controlling the rate and anticoagulating him based on his CHAD score. So an individual with minimal or no symptoms, anticoagulation and rate control. With symptoms, we try to restore sinus rhythm. So that initial encounter with the patient and focusing really importantly on symptoms is key. Now we've learned through major trials, looking at rhythm control, trying to reestablish sinus rhythm versus rate control, that the rhythm control strategy is not superior, that therapy in the patient who's maintained in sinus rhythm needs to include anticoagulation based on the CHAD score. And even though the patient's in sinus rhythm, if they have a CHAD score of 2 or higher, warfarin is still needed. And they're not mutually exclusive strategies at all. As the AFib persists and becomes lasts longer than 48 hours or becomes permanent, our therapeutic options for restoring sinus rhythm become more limited. And rate control and anticoagulation is used in about 3/4 of patients clinically across the board. If they have a lot of symptoms, they work their way to me because typically the medications aren't working. Now we have a number of antiarrhythmic agents that have just been updated in the 2011 guidelines, and they're very specific to the type of structural heart disease, including no heart disease, hypertension, coronary disease, and heart failure. But increasingly, these drugs are in the domain of the electrophysiologist. They have a lot of advantages, they have potential toxicities, and you really need to know these drugs, selecting the right drug for the right patient. Pacemakers don't work. Despite a number of trials, what has been learned is that pacing does not work to prevent AFib. Surgical ablation is emerging. There are a number of innovative technologies that can isolate the pulmonary veins, but unfortunately the quality of the evidence with surgical trials is really very poor, up until a recent large publication by Barnes Hospital, Ralph Damiano, that really shows that in experienced hands with very good follow-up, 1 year free of drugs, surgery can work. But right now there are about 6 competitive technologies that aren't really being studied appropriately with randomization. This device got a lot of attention. It's a closure device that can be put in through a vein into the left atrium. Suffice it to say that the FDA has not approved it. The theory being that if you occlude the left atrium and that this area endothelializes, you'll be in a position where you can thereby reduce the risk of stroke and eliminate Coumadin. The data is really not conclusive on this, so it's continuing in a registry, but the occlusion devices just haven't panned out clinically. Now, by contrast, AFib ablation, really based on this seminal observation of Michel Hassaguer, has taken off. And we'll go through very quickly some aspects of this, but essentially what we do is we go over into these pulmonary veins, here shown anatomically, and we have an approach where we do a wide area circumferential ablation, like this, to isolate their activity. Or we can actually just locally isolate them. The theory is the same, really, to prevent that from coming out. And we do this with very sophisticated tools. There's a whole industry that's been developed looking at not only fluoroscopic techniques, but intracardiac echo and advanced mapping techniques that really allow you literally to look inside these vessels, as is shown here, to make these procedures more successful and safer. And in that respect, what we do is essentially go over and notice a little puff of smoke here. We're cauterizing those veins, just simply taking and isolating them electrically in the 4 pulmonary veins in the patients with paroxysmal AFib. Now, when we do that, and these trials have been randomized, we've done 5 randomized trials that show that the AFib ablation works much, much better than drugs. There are a lot of limitations to these trials. There's a large trial going on really to try to look at this, but we're putting in the context of really trying to improve the quality. Now, in that respect, we do the clinical trials. We develop guidelines, and Sam's referred to some of them. We actually develop performance measures that physicians can look and see whether they're practicing by the guidelines. We educate to alter behavior and then look at the outcomes. And there's a whole methodology to this that we won't go into that involves evidence development, reviewing it, developing guidelines, developing performance measures. And increasingly, physicians are actually going to be held accountable electronic medical records with quality in a way that's going to be publicly reported with performance and appropriateness criteria built into them as well. So AFib is effective as second line for patients with paroxysmal AFib who have failed a single drug, but there's not a lot of good data beyond that. Now, when we put these guidelines into electronic medical records, it improves the quality. And this has been shown in a number of trials that with higher quality scores, the mortalities are lower. And we're all going to live in a world in which quality and performance is built into the electronic medical record under healthcare reform. And this relationship between better medical records and medical care really, I think, holds a great promise of improving the quality of care for the individual patient by holding physicians accountable for what they're doing, both for quality metrics and for public reporting. Now, in that respect, there's a methodology here, and as the strength of the evidence gets very good, like anticoagulation for AFib, and as the data integrity and the physician control gets very, very good, you move into a domain in which there's public accountability. And this kind of data is going to be out there, probably physician-specific and certainly institution-specific in the near future. And when anyone's measured based on what they're doing, it modifies their behavior. And although physicians, by their nature, are pretty autonomous and they resent this kind of thing, I think we all learned that in the long run, it really is going to improve patient care. So let me wrap things up in the remaining minute and a half here by saying that these quality and performance measures will be embedded in many dimensions of clinical care. Physicians and healthcare systems are going to be undergoing a major reform in which there's going to be evidence base and cost built into all of this with comparative effectiveness. And the improvement is a continuous cycle of discovery, clinical trials, guidelines, performance measures, looking at outcomes, and then modifying what you do. And of course, cost will be built into that. And the requirement for public reporting is going to be built into it as well. And these systems are going to be built into electronic medical records and will really dramatically change, I think, the way we practice medical care. So let me conclude by saying that, as you know from the epidemiology talk, AFib is increasing, particularly in older patients. Anticoagulation definitively reduces the risk of stroke with some of the highest evidence base that we have in any area of cardiovascular medicine. Recent clinical trials show that rate control is the preferred strategy, and rate control can be achieved in most patients. Pacing and surgery play really very limited role right now in prevention and treatment of AFib. AFib is reserved for patients who are highly symptomatic, have failed a drug, and have paroxysmal AFib. And we did clearly more research to understand the fundamental mechanisms of AFib. And once we do that, I think we'll be in a better position to treat AFib. So with that, Sam, I have 1 second left, and I'll wrap things up down to the millisecond like a good electrophysiologist.